Well, welcome back to our second week together. As we talked about last week, it's crucial as you begin your journey as a practice transformer to envision your goal and where you intend to end up in terms of transforming practice, transforming policy, improving clinical service delivery, because with that goal in mind, then you can focus more directly on how to get there when you know where you are and where you want to go. And so this course is designed to develop and refine, foster your skill development so that you will become even more effective transformers of practice and policy. So let's embark together on that journey and look at one model for transformation. We've talked extensively about the gap between what we know in theory, what we know from evidence and science and Ben's research and pharmacotherapeutics and best practices and what we do. But as a DNP prepared health professional, you have a new skill set. You are developing a new skill set, even through this first DNP project course, to bridge that gap and to transform practice. So we talked last week about how we're going to use two models, the Melnick's evidence-based practice process, as well as a model for sustained transformation, to be our roadmap and our guide as we move from our current practice state to an improved future practice state. We want that change to not just be change, but to be transformational, to result in interventions that can persist and sustain so that we maximize our investment and our effort. So as we get this roadmap, have clarity on our vision, we're going to go through our course using those models to help us gain increasing clarity on our vision and our direction. Apply their insights to the context where we're working with our clinical partners and create projects in our DNP program that transform health in that arena. So in the course, we said you're going to be reading a lot, internalizing, understanding, being exposed to these new models at the beginning. So it's very content heavy at the outset. And as we move ahead, it's going to move more toward application. So at the beginning, you're focusing on content and you're paying it forward. The time that you invest now to understand these models, to get their key components is going to pay off richly as you move toward application. So as you focus on application in the second half of the course, you're going to have fewer reading assignments and more opportunities for coaching, whether that be peer-to-peer coaching and feedback or with faculty. And you'll design these weekly assignments based on your readings. You'll do them in draft form, and those will contribute to the final prospectus that you write at the end of the term. So let's take a look at this roadmap for sustained transformation. We overviewed it on your first semester Saturday in the program. We took a look at it again last week by way of overview, but now I'd like to talk about the principles in more detail and begin to apply them to a practice setting so they become real for you in your own transformation proposal. So this model of sustained transformation really came out of the question of how do we sustain change? And so in the mid-90s, the Rockefeller Foundation commissioned a review to look at what characterized community-sustained change over a 100-year period. So there's an extensive review of the principles and the characteristics and the nature of changes that began and persisted over time, and those were distilled down into the seed scale model, which is recorded in Carl Taylor and Daniel Taylor-Ide's book that you have for this course. And that book has been used widely. The model has been used widely in other contexts. There's a sequel to this book called Empowerment on an Unstable Planet that takes about 20 years of field testing the model after it was distilled down from evidence to model and then tested and reapplied and modified. So the schematic diagram that we're using in this course actually incorporates both the original model of the 100-year review, some feedback on the model after implementing it in practice, and then it's been focused in on your practice as a DNP student. So we'll walk through each part of this model together. The first is the catalyst for change. And as we said before, there can be any number of catalysts, from changes in policy to personal frustration or discomfort in your practice setting. And for the DNP project, one of the catalysts is that this is a requirement of graduation, so you have to have a DNP project. And there's also probably a component of your own passion. You're identifying topics and areas where you want to become practice experts. And so you're merging the requirements of the program with your professional skills and your hopes for the future, but you're also blending that with the clinical practice partner's needs. And so those three things coming together really form the catalyst for your DNP project. And as we go through this process in the first course, we'll be using the principles and the process of sustained transformation so that your projects will have a transformative impact that can be sustained, can be innovative, can be customized, adapted to other settings, as well as implemented in the setting where you're doing it. So let's begin by looking at these 4 principles for sustained partnership. I'm going to talk about them, and then I'm going to give you a few small examples of how they work in practice. So the first principle is that you are building on the successes of the organization or community where you're working. And this is contrary to the dominant models of problem identification, where you go and you find the gaps and the challenges, you identify the gaps, and then you try to fill them. Certainly there's an element of that we'll be doing in the DNP project using the problem statements later on in the course. So we do identify gaps, but one of these key principles is that we're building our intervention on the successes of the community. We're building the strategies to address the problems on the successes of the community we're referring to. And that community might be a policy advocacy agency, it could be a health system, it could be a clinical unit. And so whatever domain of practice that you're working on, think about that as the community that you're working with and figure out what their strengths and successes are and build your intervention on those. The next principle invites you to build 3-way partnerships for your interventions. We talked on Semester Saturday about how interventions and changes that come in one direction often are unsustained and are dead ends. In this model, we talk about 3-way partnership: a top-down, power controller, decision maker, policy maker; a bottom-up, the frontline implementers, people who are affected by the change day to day; and outside in, people with technical expertise regarding the change. So if you think about this in terms of your practice site, you want to think about the decision makers, the frontline implementers, and people who have technical expertise. And one of the ways that we use this 3-way partnership model in the DNP program is that the faculty oftentimes that you'll identify for your project have expertise either in the arena or the method or the context where you're conducting your DNP project, and they can serve as a technical expert to support the design of your project. The top-down partner in your situation might be somebody who has administrative control. It could be a unit lead, it could be a CEO of a healthcare organization or the lead of a political advocacy group, somebody who has decision-making power over the community or group that you're working with. And then the frontline implementers, in some ways you'll be a frontline implementer in your DNP project. You'll be taking your ideas into this context and putting them into practice. There could also be other bottom-up partners, perhaps staff nurses who are providing care at the bedside in a clinical unit, But regardless of the context, there will be these three partners. And this principle tells us that we need to bring all three together in a relationship of equality and power sharing so that no one partner's perspective dominates over the other. And if we have a top-down partner who takes a domineering or controlling approach and tells the technical expert and the bottom-up implementers what to do and how to do it, you can imagine you decrease the buy-in of your frontline implementers, and you also negate their expertise. As people on the front lines of implementation, they're going to have the best contextual knowledge about how to get change and transformation into practice, much more so than the decision maker who may have ultimate control or power. So when you bring all three together and they share power and they share voice, you gain the perspectives of all three so that the project or the implementation that you design can be as strong as possible. The third principle is that decisions must be guided by data that's locally understandable, locally relevant. So if you're working in political advocacy, the data that is meaningful to your implementing partner might not be extensive scientific evidence with all of the statistical models and the p-values and the confidence intervals and the point estimates and the attributable risks and the population attributable risks and all these technical statistical numbers. But the data needs to be concrete and specific to the context where you're working. So you may have to generate those data from your project. They may be locally available in the context and you have to access them to design your project. But decision making, when all three partners are working together, needs to be guided by data that all three partners are looking at, all three partners are interpreting, and then all three partners are creating interventions from those data. And finally, the fourth principle is that practice change is the focus of the work. If you think about communicating knowledge or educating or doing some of the traditional interventions in American healthcare, they're often not sustainable because they don't focus on behaviors, practices, processes, structures of care. So thinking about how do you tap into the existing practice and modify it or adapt it to fit the data based on the insights of the three partners and using the successes of the partners to create the change plan. Those are the four principles for sustained success. If you have any one of those key principles missing, you're very unlikely to sustain change. And by way of example, I had an opportunity I was invited to be a consultant in a tertiary hospital's referral center for a subspecialty surgical practice. And they observed administratively that they had a high turnover in physician's assistants and nurse practitioners in the surgical practice. And it was believed that the challenge was related to education of primary care clinicians into a specialty practice. And so a priori, the administration had believed that they needed an educational intervention to retain these staff. So that was the catalyst for change. And as we began to assess the situation and gather local data on clinical practice and flow and talk to physicians, assistants, and nurse practitioners who are currently in practice, we found that it was very little about knowledge and education to the practice that was resulting in the attrition of clinicians, but it was much more in terms of the flow and the culture of that practice. And so we created some strategies to build on the successes of the surgical team and the PA and the NP teams in order to retain those clinicians. But one of the challenges that we had is that there wasn't buy-in from the top-down partner, and so ultimately the success plan didn't catalyze change because we didn't have that buy-in. So this ends part one of our practice.